Hello everyone, welcome back to the channel. Myself Dr. Dishant Singh, and in today's video, we're going to deep dive into the world of ECGs. ECGs is, I would say, one of the most basic investigations in medicine, and one of the most powerful investigations if you know how to interpret the ECGs, right? So whether you are an MBBS student, first year, second year, doesn't matter. Even if you are a resident and don't have a systemic plan to approach an ECG, this video might be of help to you. Now, I have made this video with the intention of including everything that is asked in the exam, almost covering 90 to 95% of the things that are asked in the exams. So, in this video, I will start with the absolute basics of an ECG. What is an ECG, how it works, and what is its use in clinical practice. And by the end of this video, guys, you will not only have a systemic plan to approach each and every ECG, but you will also have enough confidence to tackle the complex ECGs in your daily practice as well, right? So let's deep dive into the topic, guys, and decode the secrets of heart. So let's start with the topic, guys. Now, before diving into the topic proper, I would just like to tell you an overview what is an ECG, how it works, right? So first of all, what is an ECG? ECG is nothing but a graphical representation of the electrical activity of the heart, right? So whatever electrical impulse is generated in the heart, we transform it into the form of a wave or deflections on a graph paper, and we interpret the ECG, right? Now, there are multiple electrodes that are placed over the human body, and these electrodes pick up the electrical signals that are generated over the heart by the heart. Right now, the most common ECG that is used in India is a 12 lead ECG. Right. So, what we have is a 12 lead ECGs. Right. Uh, Three are limb leads, three are augmented leads, and the rest six are chest leads. Right, guys. I will tell you what is this one by one. So, in the 12 lead ECG, the three limb leads are 1, 2, and 3. Right. So this diagram is Hypertrophy triangle. Now, in this diagram, you can see there are three leads: lead 1, lead 2, and lead 3. Right? Three leads are there. Now, if you look at these leads, each lead has a negative terminal and a positive terminal, right? So these are bipolar leads, right? So the three limb leads 1, 2, and 3, all of these are bipolar leads. So the direction of the movement of the vector is from negative end to the positive end. So for lead 1, it is from the right upper limb to the left upper limb, right, guys? And same for second lead is from right upper limb to the left lower limb, and for third lead it's from left upper limb to left lower limb. Now, if you see here, guys, the right leg is not included for an electrode or for a lead because it serves as a ground or it serves as neutral, right? Now, we have three augmented leads: AVR, AVL, and AVF. These are called as augmented because the amplitude in this is adjusted to 1.5 times its original value. That is, the amplitude in these leads is increased to 1.5 times of the original value, as a result of which it is called as augmented leads, right? Now, all these augmented leads are unipolar, guys, right? So, if you see this lead here, right arm, and left leg, right? So, we have AVR for right arm, AVL for left arm, and AVF for left foot, right? All of these augmented leads are unipolar leads, right? One thing I forgot to mention, guys, there is a formula which was given by Anthoven, which states that the sum of the amplitude, of lead 1 and lead 3 equals lead 2, right? So this is just a formula you need to remember. It may be asked in the exam, right? Now, we talked about three limb leads and three augmented leads. Now, we're going to talk about six chest leads, which are V1 to V6. If you see this diagram here, you can see there are six chest leads, right? V1 to V6. Now, uh, talking about the placement of these leads over the chest, V1 is the only lead which is placed on the right side of the sternum, right? If you see here, V1 is placed on the right of the sternum, and it is the only lead which is placed on the right of sternum. The rest of all leads are placed on the left side of the sternum, right? So here you can see the placement of all these electrodes, and so V2 is placed in the fourth intercostal space on the left of sternum. V4 is placed in the fifth intercostal space, right? So V2 you can see here in the fourth intercostal space, just left of the sternum, and V4 in the fifth intercostal space in the mid clavicular line, right? and V3 is between V2 and V4. Now V5 is in the anterior axillary line, left anterior axillary line, as you can see here. Left anterior axillary line, V5 is placed, and V6 along the mid axillary line, right? So this is what the graph paper actually looks like, right? So if you see here, the graph has one large square. So the one that I marked just right now is a large square. And within each large square, you can see there are 25 small squares like this, right? 5 horizontally and 5 vertically, right? So in a large square, there are 25 small squares. Now, you need to remember that every large square, every large square has a duration of 0.2 seconds, right? So on the x-axis, we write as the time, and on the y-axis is the amplitude, right? Yes. So every large square has a duration of 0.2 seconds, and every large box has an amplitude of 0.5 millivolt, right? So since the large square has 0.2 seconds, if we divide 0.2 by 5, we will get the duration of each small box, which corresponds to 0.04 seconds, right? Yes. So 0.04 seconds. Similarly, for each small box, the amplitude is 0.1 millivolt. Okay, guys. So this is the representation in the graph paper of ECG. Now, talking about the conduction of impulses in the heart, we know the impulse is generated in the SA node, which is located in the right atrium. It then passes to the atrioventricular node, AVN. From AVN, it passes into the bundle of his, right? And from the bundle of his, it goes into the left bundle branch and the right bundle branch. And from the bundle branches, it goes into the corresponding Purkinje fibers, right? Now here you need to remember the impulse velocity is fastest in the Purkinje fibers because of the highest number of connexons, right? That is the gap junctions are highest in Purkinje fiber, as a result of which the conduction velocity is also highest in case of Purkinje fibers, right guys? Now, I told you there are 12 leads in the ECG. Whenever uh, electrical impulse is generated by the heart, right? So that electrical impulse is translated into the form of a wave, which is plotted in the ECG paper. For example, this this is the electrical wave for a complete cycle of the heart, right? So P corresponds to atrial depolarization, QRS corresponds to ventricular depolarization, and TVS corresponds to ventricular repolarization. Now, guys, before the actual contraction of the heart, first heart has to receive, or the heart muscle has to receive a signal, right? So, atrial depolarization is the event occurring before atrial contraction, right? So, mechanically, before the contraction occurs of the atria has to first depolarize itself. Similarly, for ventricle also, before actual ventricular contraction takes place, ventricular depolarization has to take place, right guys? So, P wave corresponds to atrial depolarization, which is an electrical activity. After P wave, the atria will contract, right guys? So, you can see here, we have P wave for depolarization of atria, QRS for ventricular depolarization, and T wave for ventricular repolarization. But there is no wave for atrial repolarization, which is, and that is because, guys, the atrial depolarization coincides within the QRS complex itself. The amplitude is much, much smaller, as a result of which it coincides within the QRS complex and cannot be seen as a separate wave. Right, guys? Now, I will tell you about the significance of each of these later in the video. We also have something called as a U wave, which is seen in some specific conditions like hypokalemia, and it is seen following T wave, right? So after T wave, U wave is usually seen in cases of hypokalemia, right? Now, apart from the wave that we just discussed, we also have what you call as a segment, right? So, this wave is called as a P wave. This isoelectric line, the straight isoelectric line, is called as a segment, right, guys? And the combination of this wave and a segment is called as the interval, right, guys? So, P wave and So P wave and PR segment, both of these combined to form the PR interval. Right? Yes. Now, if you see here, PR interval starts from the onset of P wave up to the end of PR segment, which corresponds to the depolarization of atria up to the impulse reaches the ventricles, right? So this is the time taken for the impulse to travel from atria to the ventricles, right? So whenever is this duration is enlarged or the duration is increased, we can say there is some defect in the conduction, right? From atrial to ventricle, as a result of which there is increased duration. For example, in cases of heart block, we will see there is increased PR interval, right? PR interval is normally 0.12 to 0.2 seconds, right? Let me just correct this, guys. It is 0.20 seconds. Okay. So the PR interval is usually 0.12 to 0.2 seconds, which corresponds to 3 to 5 small blocks. Correct, guys? So after that, we can also see there is an ST segment, right? Now, the place where the S wave ends and the T wave starts, between them is isolated line, which we call as ST segment. Also, guys, we have also something called as J point, right? So what is J point? J point is nothing but the end of the S wave and the commencement of the T wave, right? The point where the S wave ends and T wave commences is called as the J point, right? The significance of it we will learn later, right? Similarly, we have something called as QT interval, which starts from the Q wave and ends at the end of T wave, right? QT interval is the sum of complete electrical activity of the heart. For example, the QRS corresponds to the ventricular depolarization and T wave corresponds to ventricular depolarization. So the QT interval includes both ventricular depolarization as well as the ventricular repolarization, as and hence represents the complete electrical activity of the ventricles, right? Now, going now, for each and every surface of the heart, we have leads that are corresponding to them. For example, for the inferior surface of the heart, we have lead 2, 3, and AVF. So, whenever there is a pathology in the inferior surface of the heart, there will be a corresponding change in the inferior leads, right? Which is lead 2, lead 3, and AVF. Similarly, for lateral side, that is the left lateral side, we have lead 1, AVN, V5, and V6. For anterior, we have V3, and for septal, we have V1, V2. Right, guys? Also, in this diagram, you can see this is superior, this is inferior, this is left lateral, and this is right lateral. Right? So, you can see here on the inferior side, we have 2, 3, and AVF, right? So, for the inferior surface of the heart, we have leads 2, 3, and AVF. For left lateral side, we have 1 and AVL, right? So, lateral, we have 1 and AVL. For the right side of the heart, we have AVR, and you can see here for the septal part of the heart, we have V1 and V2, and for the anterior part, we have V3 and V4, right, guys? Also, apart from the leads, you can see here some degrees which is written, right, guys? So, degree, this is used to calculate the axis of an ECG. So, each and every ECG that you see has some axis, right? I will talk to it later, but just remember, guys, about the surface of the heart and the leads that correspond to it. Right? So now let me just show you what a normal ECG looks like, right? So here you can see the three limb leads, 1, 2, and 3, the three augmented leads, AVR, AVF, and AVL, and the V1 to V6, 6 chest leads, right? So this is a 12 lead normal ECG which I am demonstrating here, right here, right? So in this you can see this is a P wave, this is the QRS complex, and this is a T wave, right? So if you see vertically also, this P wave and this P wave come at the same time, right? So a lot of times you may confuse P wave and a T wave. So with this trick, you can find out whether it is a P wave or T wave, right? You just have to see longitudinally downwards. and each ECG will have the same wave at the same location, right? For example, this is the P wave here also, this is the P wave here also, and this is the P wave here also, right? Now, what I want to do, see in this, is that whenever the wave is upside, it is a positive deflection, and whenever the wave is downwards like this is a negative deflection, right? Now, what I want to see you to see here is that the deflections in lead AVR are negative. You can see the P wave also, the QRS and the T wave, all three are negative in case of AVR. Suppose this is SA node and this is AB node, right? So the direction of the movement of the impulse is like this, right? In this direction. But I already told you that for lead AVR, the positive terminal is there and negative terminal is here. So the direction for this vector is this side, right? And the direction of the movement of the impulse is this side. As a result of which both are opposite to each other, hence all the deflections in AVR are usually negative and it is a normal finding, right? And you can see here in lead V1 we have a negligible, we don't have a R wave, right? In V2 we have some sort of a prominent R wave, then a slightly more prominent in V3, more prominent in V4, and V5, V6 have a prominent R wave, right? So S wave is prominent in V1, again S wave prominent in V2, S in V3, right? So as I move from V1 to V6, R becomes more prominent and S becomes less prominent, right guys? So this is what a normal ECG looks like. Now I will tell you how to interpret an ECG step by step in a systematic manner, right? So first of all, we will learn about the how to calculate the heart rate by looking at an ECG, then determine the rhythm of the ECG, whether it is regular rhythm or irregular rhythm. We have to then determine the axis that I was talking about earlier. Next, we have to see the individual waves. If there is any abnormality that we can see in individual waves, then we have to calculate the intervals, access the hypertrophy of the chambers of the heart. For example, if is there hypertrophy of the right atrium, left atrium, right ventricle, left ventricle, we can see that by looking at an ECG, and we'll try to learn that. And finally, look for the evidence of infarction and dyselectrolytemia, right? So, what are the changes that we have to look for if you want to diagnose a patient with MI, right? And what are the changes that can be expected in an ECG when patient takes certain drugs like digoxin or amiodarone, and in certain conditions such as hypokalemia, hyperkalemia, hypomagnesemia, hypermagnesemia, hypercalcemia, hypocalcemia, right? So all this we will see step by step in a systematic form. Now, this is the stepwise manner that I want you to think, or that is the systematic manner that I want you to make a habit of whenever you are looking at an ECG, right? So first of all, we will take a look at the rate. First of all is how to calculate the heart rate by looking at an ECG, right? So we have basically two methods. Now, first method says that, now here you can see this is a P wave, this is a QRS complex, Q, R, S, and the T wave, right? Now, what you have to do is in a particular lead, right? So there are 12 leads, right? Whenever you're looking at an ECG for any irregularity or heart rate, try to look at lead number 2. Lead number 2 is also called as the rhythm lead, and it is found to be most accurate, right? So whenever we're trying to look for a particular pattern or heart rate, whenever looking, just try to look at lead number 2, right? Now, that is the rhythm rate. Now, so for calculating heart rate, we have to first see what is the RR interval, which means that what is the distance between the two R intervals, two R waves to be exact. So the distance between two R waves is called as the RR interval, and we have to calculate that. So for here, this example, you can see between this R and this R, we have 1, 2, 3, and 4. We have 4 large boxes in between these two R waves, as a result of which the rate is 300 divided by the number of large squares between two R waves. So here the number of large square between two large boxes is 4, as a result of which heart rate comes down to 300 divided by 4, which is approximately 75 beats per minute, right? So we know normal heart rate is between 60 to 100, and whenever the heart rate crosses more than 100, we have what is called as tachycardia, and below 60 it is called as bradyarrythmia, right? So normally between two R waves there should be 3 to 5 large boxes. If there are 3 large boxes between two R waves, then the heart rate is around 100, And if there are 5 large boxes between two R waves, then heart rate is around 60. So between 3 to 5 large boxes should be present between two R waves, right? So the second method is we have to calculate the number of small boxes between two R waves, right? So in this here you can see there are two large boxes, which means approximately 10 small boxes, right, between these two R waves. Now we have to divide 1500 by the number of small squares between two arrears. So here it comes down to around 10. So the heart rate here will be 1500 divided by 10, which comes down to 150 heartbeats per minute, right? So this is the second method that you can use, right? So now we know how to calculate the heart rate by looking at an ECG. The second step is to determine the regularity of an ECG, right? Whether the ECG that we are saying is regular or not. How to do this is just try to take a look at lead number 2, right? So what you have to do, this is a P wave, this is a QRS complex, and this is a T wave, right? Now you have to calculate the distance between two R waves. When you try to zoom in into that, we'll see there are approximately 1, 2, 3, 4, 5, 5.5 large boxes between two R waves, and same is for all the R waves, right? So the distance is same between all the R waves, which is called as a regular rhythm, right? So since the distance between each R wave is equal, we call this as a regular rhythm, right? Again in this you can see the distance between R waves is equal. So this is a regular rhythm. Again here also the distance is equal. Here you can see there is difference in the distance between two arrays. This one is shorter and this one is wider, right? So this is called as irregular rhythm, right? Now, irregular rhythm is commonly seen in atrial fibrillation and atrial flutter, right? So this is what you have to remember, guys. Whenever we are saying that the rhythm is irregular in an ECG, the first thing that should strike our mind is atrial fibrillation, right? Atrial flutter can have normal rhythm as well as irregular rhythm, but one thing is sure that whenever we are looking at an ECG which has an irregular rhythm, the first thing that should come to our mind is atrial fibrillation, right, guys? Now, what is atrial fibrillation and atrial flutter? Now we know that the normal impulse generates in the atria in the SN node, right? So normally what happens, guys, is atria contracts and ventricle relax. Then ventricle contracts, atria relax, right? This is how the contraction of in the various chamber of hearts takes place, right? Now what happens in atrial fibrillation or atrial flutter? So normally the atria contracts like this, completely contracts, then completely dilates. So systole, complete diastole, systole, diastole, systole, diastole. In case of atrial fibrillation and flutter, what happens is there are ectopic generation of impulses, right, in the atria itself. So there are multiple sites at where impulses are generating, as a result of which the atria contracts incompletely. So instead of contracting like this, it contracts like this. So it partially contracts, as a result of which the diastole and systole both are of reduced duration, right? So the heart rate in atrial fibrillation is much higher as compared to the heart rate in atrial flutter, right? So you can see the atrial rate is around 350 to 600 in atrial fibrillation and up to 350 in flutter, right? Now the thing that the waveform that differentiates them is the presence of this sawtooth appearance, right? Here you can see, guys, there is a sawtooth appearance of the waves, on the P waves, right? So this is what is called as the sawtooth pattern of atrial flutter, right? And in atrial fibrillation, you can see there is no proper P wave, right? No properly distinguishable P wave is seen in atrial fibrillation. So with irregular rhythm, there are no P waves that may be seen in case of atrial fibrillation, right, guys? Now, one question you should ask yourself, guys, that when I told you about calculating heart rate, I told you to calculate the distance between two R waves, right? But in atrial fibrillation, when the distance between each R wave is different or we have an irregular rhythm, then how do we calculate heart rate in such a situation, right, guys? So, what we have to do, guys, is that we have to count 30 large boxes, right? So, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Like that, we have to count till 30, right? And then we have to calculate the number of R in these 30 boxes, right? For example, suppose 1, 2, 3, 4, 5, right? 5 R waves are there in 30 boxes, right? So we know each box, large box correspond to zero point 0.2 seconds. So if we calculate 30 boxes, it will correspond to 6 seconds, right? So in 6 seconds, there are 5 R waves. So if we multiply 6 by 10, we will get 60 seconds, that is 1 minute. So if we also multiply the 5 R waves by 10, we will get 50 beats per minute, that would be our heart rate, right? So what you have to do is to calculate 30 large boxes and to calculate, find out the number of R waves in those 30 large boxes. Once we have calculated that, we have to multiply that by 10 and we will get the desired heart rate in case of an irregular rhythm or in case of atrial fibrillation. So guys, now we know how to calculate the rate of the ECG and how to check the regularity of an ECG, right? Next thing is to look for the axis of an ECG, right? As I already told you, normal QRS axis is from -30 to +110. Now I want you to look at this diagram, right guys? Which I also showed you earlier as well. You can see here 0 degree, 90 degree, 180 degree and -90 degree, right guys? So the normal axis of ECG lies between -30 to +110. In some books you will find -30 to +90 or 0 to 90, but most commonly followed is -30 to +110, right guys? So this is normal axis of the ECG, right? Or the normal axis of the heart. Now, whenever there is an axis which lies to between -30 and -90, we call it as a left axis deviation. I will tell you how to calculate, don't worry guys. Just now focus here. Between +110 and 180, we have what we call as the right axis deviation, and between -90 to 180, we have extreme axis deviation or no man's land. So, for calculating the axis of a ECG, what we have to do is we have to just look at two leads, right guys? That is lead one, sorry, and lead AVF. Two leads, lead 1 and lead AVF. For example, let's look at this ECG. You can see here, this is lead 1 and this is lead AVF, right? Now this is a P wave, this is the QRS complex and T wave, right? So we have to look at the QRS complex. In this, we can see there is a positive deflection in QRS wave, and in AVF also there is a positive deflection, right? If both 1 and AVF have positive deflection, then we have what we call as the normal axis. Positive in both lead 1 and AVF, we have a normal axis. That means the axis is between -30 to +10, which is a normal. Here you can see in lead 1 we have a negative deflection in QRS, and in AVF we have a positive deflection in QRS, right? So here lead 1 has a negative deflection, right? So if you see, one is downwards and other one is upwards. So it looks like they are both reaching for each another, right? So this is when you have a right axis of the heart, right? In which the lead 1 is negative and AVF is positive. We have the right axis. So the right axis lies between +110 to +180. Right guys? Next, if you look at this ECG again, you can see there is a positive deflection in lead 1 and a negative deflection in lead AVF. So one is upwards and other one is downwards, right? So it looks like they are leaving each other, right? So in this condition, we have a left axis deviation, right? Reaching, leaving, right? So between -30 to -90, we have what we call as the left axis deviation, right? Now, if you look at this ECG, here both 1 and AVF have negative deflection, right? So when the deflection is negative in both the leads, we have called as the northwest axis, which is also called as the extreme right axis or no man's land, right? It is the most, what we can say, a rare type of axis, right? So I told you the 4 axes that are there: normal, left axis deviation, right axis deviation, and northwest axis or extreme right axis, right? Now we know how to calculate the heart rate in an ECG, how to check for regularity in an ECG, and how to calculate the axis of an ECG. The next step is to check the individual waves of an ECG, right? Now, first of all, we will look at the P waves. P wave is always positive in lead 1 and 2, right? So it will always have a positive deflection in lead 1 and 2. If it has a negative or a inverted P waves are seen in lead 2, it is suggestive of dextrocardia. That is, the heart is placed on the right side of the chest cavity, right guys? Now, P wave is always negative in lead AVR, I already told you. Then, if you look at the amplitude or the height of the P wave, the normal height of the P wave is less than equal to 2.5 mm, which corresponds to less than equal to 2.5 small squares, right guys? So that is the normal amplitude or height of the P wave. Whenever the height of the P wave exceeds this 2.5 small boxes, then we have what we call as the P pulmonary, which means there is a right atrial enlargement in the patient. Similarly, if the P wave has a bifid nature, for example M-like pattern, right? So you can see here the wave is bifid. We call it as the P mitral, which is called which is the left atrial enlargement in the patient, right? So next is P waves can be commonly biphasic in lead V1, right? So what's biphasic? This is what we call as being biphasic, right? So it has a positive deflection also and negative deflection also. This is the biphasic, and P wave can normally be biphasic in lead V1, right? Now, as I already told you, P waves are absent in atrial fibrillation or flutter. So, next we are going to talk about tachyarrhythmia and bradyarrhythmia, right? So, as we already talked, whenever the heart rate is more than 100, it is called as tachycardia, and whenever it is less than 60, it is called as bradycardia. Now, suppose you are looking at the ECG of a patient which has a heart rate more than 100, then you know what, that he is having a tachycardia, right? But there can be multiple reasons for this tachycardia and multiple types of tachycardia. So how do we know which type of tachycardia it is? Now, as soon as you know the patient is having tachycardia, what you have to see is you have to look at the QRS complex. QRS complex. Now, the normal QRS complex is a narrow QRS complex. What do we mean by that? That the QRS complex, normal QRS complex, has a duration that is less than or equal to 3 small squares. That is up to 0.12 seconds, right? So, what I told you guys, that whenever you calculate heart rate in an ECG and the patient is having more than 100 beats per minute, that means he is having tachycardia. After that, you have to see whether the QRS complex is narrow or wide. So, whenever the duration is less than 3 small square boxes, then we call it as a narrow QRS complex. And if it is more than 3 small square boxes, we call it as a wide QRS complex, right? So, if the patient is having narrow QRS complex, then we have to see whether the rhythm is regular or irregular, right? I already told you in atrial fibrillation the rhythm is irregular, right? And also the PFs are absent. Next, differential for irregular rhythm with narrow QRS complex is multifocal atrial tachycardia. What we mean by that is there are multiple foci in the atria which are generating impulse at the same time, as a result of which there is tachycardia that is originating in the atrium itself, right? So characteristically in multifocal atrial tachycardia, we see 3 different PA morphology in lead 2, right? Now guys, I will show you all this ECG one by one. Don't panic right now, just try to understand what I'm telling you right now, right? We will see all the ECGs in detail. Okay, so a patient was having tachycardia. We interpreted the QRS complex. We found out the QRS complex is narrow because the QRS complex is less than 3 small squares. After knowing it is narrow, we have to see the rhythm. We found the rhythm to be irregular. Then the differentials were either AFib if there was absent PF, and if the PF was present and more than 3 different PFs morphology was seen, it is multifocal atrial tachycardia, right guys? Next is, what if the rhythm was regular, right? First differential would be sinus tachycardia. For example, whenever we exercise or whenever we run, right, we will also have increased heart rate, that is above 100, that is we will also have tachycardia. But everything in the ECG will be normal. normal P waves, normal QRS complex duration, and normal T wave. Everything will be normal. That is what we call as the sinus tachycardia. That is, the tachycardia is because of the sinus that are generated in the SN node itself. That is sinus tachycardia that we normally have. That is the normal individuals have, right? That is not having any pathology, right? Next is SVTs, supraventricular tachycardias, right? Now, if you look at the word supraventricular tachycardias, these are the tachycardias that arise above the ventricle, that is supraventricular, right? So these are arising in the atria itself, right? This can be of various types, such as subdivision of SVTs are AV, RT, AV and RT, junctional tachycardia. So there's multiple forms of division of supraventricular tachycardias is there. But what you have to remember is that, guys, AVRT, AV re-entry tachycardia, and AV nodal re-entry tachycardia, AVRT and AVNRT, both of these types are, the mechanism is same for both these, is that there is a re-entry of the impulse from the AV node or before going to the ventricles, right? For example, guys, this is atrium and this is SA node, and this is AV node, right? So impulse generates in the SA node, goes into the AV nodes, and then it goes below into the ventricles. Now, instead of going below from AV nodes, it goes upwards only through the atria, right? Into the atria, right? So instead of going downwards from AV node, it goes into the atria itself. That is a re-entry has been taken. It can either go to the atria or to the SA node, right? So this is what we call as a re-entry tachycardia. So both AVRT and AVNRT fall under this category. Next we have is the junctional tachycardia. Junctional tachycardia is when the SA node for any reason is not functioning properly, as a result of which the AV nodes takes over SA node as the pacemaker of the heart, and then impulses are generated from the AV node itself, right? So that is what we call as the junctional rhythm, right? Now, I already told you that atrial flutter can be either regular or irregular, right? So we looked at the narrow QRS complex tachycardias. Next is wide QRS complex tachycardias, right? So, uh, most commonly we will see only narrow complex tachycardia only. So when the QRS complex is more than 3 small squares, we call it as a wide QRS complex. The differentials can be ventricular tachycardia, ventricular fibrillation or flutter, and SVT with aberrancy, that is SVT with either blockade or bundle branch blockade, right? So if normal SVTs we have, then we put it under narrow QRS complex tachycardia. If we have a wide QRS complex tachycardia, then it can be SVT with aberrancy, that is with blocks, right? Now we'll look at them one by one, right? Now, the patient, if having heart rate below 60, is said to have bradycardia, right? Now, the differentials for bradycardia can be sinus bradycardia, right? Everything is normal. The sinus is firing at a lower level, as a result of which the heart rate is low. Next is six sinus syndrome, triple S syndrome. Six sinus syndrome, which is usually seen in the case of old age individuals, right? As a result of which there will be some phases of tachycardia, some phases of bradycardia alternating between each other, right? So it is usually seen in old ages. Next and most important is heart blockade, that is AV blockade, atrioventricular block, the blockade that is present between atria and ventricles, right? So this is called as the heart block, and heart block is a major reason for bradycardia. So there are multiple types of heart block. We will study each of them in detail later on in this video, right? As I already told you guys, the patient is having tachycardia, that is heart rate more than 100. We have to see QRS, whether it is a narrow or broad. Narrow means less than 3 small squares, that is less than 120 milliseconds, or if it is broad, means more than 3 small squares, that is more than 120 ms, right? Next, if the person having narrow complex tachycardia, we have to see rhythm is regular or irregular, right? So if the rhythm is regular, then we can have differentials such as sinus tachycardia, atrial flutter, and PSVT or SVTs, right? And if the rhythm is irregular, then again we can have atrial fibrillation, multifocal atrial tachycardia, or regular rhythm with variable conduction, right? That is some block in between, right? Now, one thing you have to remember is SVTs, like atrial fibrillation, have no obvious P waves in them, right? But the rhythm will be regular in case of SVTs, and irregular in case of atrial fibrillation, and both will have a narrow complex QRS complex. Again, guys, showing the same thing, QRS width, narrow complex tachycardia that is less than 120 ms. If irregular rhythm is there, then we can think of atrial fibrillation, multifocal atrial tachycardia, and atrial flutter with variable conduction. And if it is regular rhythm, then we can have atrial flutter, then various forms of what we already told you, that is supraventricular tachycardia, that is AVRT, EVNRT, like that, right? Again, showing the same thing only, guys. Narrow complex tachycardia, if the rhythm is irregular or regular. If it is irregular, then we know it can be either AFib or MAT. If there are no P waves, we can think of AFib, and if there are P waves present, then we can think of MAT. If more than 3 morphology of P waves present, if single morphology is present, then we can think of atrial flutter with variable flow, right, guys? Now, if you look at this ECG and go step by step, so first of all, you can see the rhythm is irregular. The duration between this and this is different, as a result of which the rhythm is irregular. And if you look at the QRS complex, the QRS complex is around 2 small boxes, that is around 0.08 seconds, which is narrow QRS complex, right? So the patient is having narrow QRS complex and the rhythm is irregular, then we can think of either AFib or MAT, right? Now you see here there is no obvious P wave that is present in this lead, right? So we will think of AFib, and this is an ECG of atrial fibrillation, right, guys? Next, if you see here, again, here also, what you can see is irregular rhythm, right? And a narrow QRS complex around 2 small boxes. But here you can see, if you see in the P waves, the P waves have different morphology, right? Some are negative reflection, positive reflection, and different amplitude as well, right? So if there are 3 or more morphology of P waves with irregular rhythm or with narrow QRS complex, then we think of multifocal atrial tachycardia. So this corresponds to multifocal atrial tachycardia, right, guys? Okay, so this was about narrow QRS complex. Next is about wide complex tachycardia. We know we call it as a wide complex when we have more than 3 small boxes, right? That is more than 0.12 seconds, right? The differentials can be ventricular tachycardia, which is the most common, wide QRS complex tachycardia. Other differentials can be ventricular fibrillation or flutter. We already talked about atrial fibrillation and flutter. And one other differential can be supraventricular tachycardia with ventral branch block or conduction pathway defect, and or some blockade in between the pathway, right? So the most important differentials to include in case of wide QRS complex tachycardia, most common one, around 80% to 85% of cases, is ventricular tachycardia itself, then ventricular fibrillation, and SVT with blockade, right? Now just take a look at this ECG step by step. Now look at this ECG, right? First of all, the distance between the 2 R waves is around 2 to 2.5 large boxes, that is the heart rate is 300 divided by, let's say, 2, that is around 150 beats per minute is the heart rate, right? Next we see the rhythm is regular, equidistant R waves, right? So we are having a regular rhythm. Next we have to see the QRS complex, right? So if you see here, right, the QRS complex, it is around 4 to 5 small boxes, that is much above the normal, that is more than 3 small square boxes, right? This. So this is a case of broad QRS complex, right? The patient is having tachycardia, which is regular, and having broad QRS complex, then it becomes ventricular tachycardia, right? And ventricular tachycardia is, I told you, the most common cause of broad QRS complex tachycardia. Now, to differentiate between ventricular tachycardia and ventricular fibrillation, you can see that both ventricular fibrillation and tachycardia have a wide QRS complex, right? Again, since both are tachycardia and both come under tachyarrhythmias, both have a heart rate much above than 100, right? Now, if you look here, the waveforms in ventricular fibrillation are bizarre and irregular, right? Whereas if you look in ventricular tachycardia, we have white curves, but the waveform is regular, right? We have a regular waveform in case of ventricular tachycardia and irregular waveforms and bizarre waveforms in case of ventricular fibrillation, right? That is the main difference between both these, right? So the rhythm is regular in case of ventricular tachycardia and rhythm is irregular in case of ventricular fibrillation, right? Now, similar to this, we have something called as premature ventricular contraction, that is PVCs, right? Premature ventricular contraction, as the name suggests, there are some premature impulses that are generating in the ventricle itself, right? So normally what happens, the impulse generate in the atria and come to ventricle, but here in this case the ventricle they themselves generate impulse, right? As a result of which, so the normal impulse that is generated in the atria, it has a P wave, then when it comes to ventricle it has a QRS. But in case of PVCs like this one, it doesn't have a preceding P wave, right? This one is the T wave, right? So the PVCs don't have a P wave because the PVCs, the impulse they generate in the ventricle itself, right? And P wave corresponds to the impulse that are generated in the atria, right? So all the PVCs don't have any form of P waves with them, right? You can see PVC here also, here also, here also, right? So uh, when there is PVC after every normal beat, we call it as a ventricular bigeminy, right? So you can see one normal QRS complex, then a PVC. Again normal wave, then PVC, again normal wave, PVC. This is called as ventricular bigeminy. Now, when there is a PVC after every two normal waves, this is called as ventricular trigeminy, right? So now we know ventricular bigeminy and ventricular trigeminy as well. Next is the T wave, right guys? So as I told you already, that T wave is nothing but a positive deflection which is seen after QRS wave, right? You can see here, this is the T wave, this is the T wave, this is the T wave, and you can see large, tall, tented T waves, right? So such large, tall, tented T waves are seen in hyperkalemia and hyperacute MI, right? Steep, tall T waves, right? These are mostly indicative of hyperkalemia and hyperacute MI. I will talk it more about it later in this video, right? Just now, for now, know this much. Next is a U wave. So I already told you, U wave is nothing but a positive deflection which is seen after T wave. This one is T and this one is U wave, right? So U wave comes after T wave, right? And it is a positive deflection and seen in specific conditions such as hypokalemia, right? So along with hypokalemia, it can be seen in hypercalcemia, thyrotoxicosis, and digitalis exposure. But most importantly, remember, U waves are most commonly seen in hypokalemia, right? U waves are said to represent the repolarization of the papillary muscles or the Purkinje fiber. So that is the significance of the U waves, right? Again, you can see tall tented T waves, and U waves, right? Now, another one is Osborn wave, right? So here you can see this is the Q, this is the R, and this is S, right? And after this square complex, after this S wave, you can see another waveform, right? So this is what is called as Osborn wave, right? Which is a positive deflection at J point. J point I told you between S and T. So after S and before T is the J point, and the positive deflection at J point characteristically seen in hypothermia is called as Osborn wave. So you will be given history of patient that is having a history of bathing in a cold lake or something like that, which demonstrate hypothermia, and in that case, Osborn wave will be seen in the ECG, right? Next is the Epsilon wave, right? So Epsilon wave is characteristically seen in ARVD. ARVD is a condition called as arrhythmogenic right ventricular dysplasia. So Epsilon wave again is nothing but a small positive deflection in the end of the QRS wave, characteristically seen in ARVD, as I already told you, right? So again, you can see QRS complex and a small positive deflection at the end of the S wave, right? So this is seen in, this is Epsilon wave seen in ARVD, right? Arrhythmogenic right ventricular dysplasia. Another one is Brugada syndrome. Now, Brugada syndrome has been asked multiple times in the exam before, so it is important to know it, right? Now, Brugada syndrome is commonly seen in leads V1 and V2, right? What we will see is that there will be coved up type of ST segment elevation. So this is what you are seeing here, right? Is called as the coved up ST elevation. This pattern. Along with the curved up ST pattern, we will see a negative T wave, curved up ST elevation with a negative T wave. In lead V1 and V2 is called as the Brugada syndrome. It is a congenital or hereditary the electrical defect, conduction defect in the heart, right? So that's Brugada syndrome. So now we know how to calculate the heart rate of an ECG, how to see if the rhythm is regular or irregular, how to know the axis of an ECG, and individual waves of an ECG. We have already seen, right? Now we're going into the calculation of intervals, right? I told you when a wave is combined with a segment, we call it as an interval, right? Now the most important interval that we need to know is the PR interval, right? I told you PR interval is nothing but, let me just show you, right? So what is PR interval? This is what is called as the PR interval. From the starting of the P waves up to the end of that PR segment. This is called as the PR interval, right? PR interval. So now the normal PR interval has a duration of 0.12 to 0.2 seconds, right? Which corresponds to 3 to 5 small boxes, right? So the normal PR interval is between 3 to 5 of small boxes. Now, whenever we are having a longer PR interval, it suggests heart block, right? So I already told you that PR interval is nothing but the time taken from the impulse to reach from atria to ventricle. So if there is some kind of block between the atria and ventricle conduction system, then there will be a longer PR interval, right? So longer PR interval suggests heart block. And if we have a short PR interval, which means the impulse takes less time from atria to ventricle to travel from atria to ventricle, right? Such is the case of WPW syndrome. We know in case of WPW syndrome, we have a accessory bundle we call it as bundle of Kent, right? Bundle of Kent is present in case of WPW syndrome, which is present between the SA node to AV node, right? So suppose this is SA node and this is the AV node, right? So this is the normal pathway, right? This one is the normal pathway. So the normal pathway has a delay of 0.1 second, that is called as the physiological AV nodal delay, right? So normal pathway has a 0.1 second of latency, or what we can say delay, which we call as physiological AV nodal delay. But in cases of WPW syndrome or the individuals with an accessory bundle of Kent, there is no delay in this pathway, as a result of which short PR interval is seen, right? So this is what we call as a bundle of Kent, right? Again, so longer PR intervals suggest heart block, and shorter PR intervals suggest there is lesser time taken for the impulse to travel from atria to ventricle, as a result of which it can be seen in WPW syndrome, as well as the LGL syndrome, that is a long Gannon-Levine syndrome. The three scientists that devised it, right? Next, we are going to study about the different types of heart block that are seen in an individual, right? First of all, the first degree heart block. Now, I told you heart blocks, how can we see? By seeing the PR interval. If the PR interval is prolonged, it suggests heart block, right? So what happens in first degree heart block is that the PR interval is more than normal. Normal, we talked about up to 5 small boxes is normal, but here you can see it is around 7 small boxes. So there is definitely a prolonged PR interval. So when there is a prolonged PR interval, there is first degree heart block, right? Next is the second degree heart block. So second degree heart blocks is divided into Mobitz type 1 and Mobitz type 2, right? Mobitz type 1 is also called as the Funky back, right? So second degree heart blocks has two types, Mobitz type 1 and Mobitz type 2. Mobitz type 1 is also called as the Funky back. Now, here what happens? Here you can see the PR interval is increasing. Here it was this much, then increased, and then furthermore increased. And in the next one you can see there is no QRS complex, right? After this P wave there is no QRS complex. So in Mobitz step 1 or Wencky Wake phenomena, there is a consecutive increase in the PR interval until a beat is missed, right? So there was a continuously increase in the size of the PR intervals until a beat is finally missed. That is, a P wave is not followed by a QRS complex. And after that, again, you can see the short PR interval, and this will prolong, right? Now, in movement step 2, what happens is that the PR interval is constant, right? You can see here the PR interval is constant, but suddenly a beat is missed, right? So there is no prolonging of the PR interval, unlike type 1, right? Here just a beat is missed, right? So this P wave is not followed by the QRS because of the some block between the atrial and ventricle, right? This 2:1 block suggests that for every two P waves there is only one QRS complex, right? So there are two P waves but only one QRS complex. Again, two P waves but only one QRS complex, right? Next and final type of heart block is third degree heart block, that is the complete block, right? Third degree or complete heart block is there is no coordination between atrial and ventricle. So you can see here P wave, then again P wave, then one QRS complex, then P, again QRS, P, again QRS, right? So there is no coordination between atria and ventricle. The atria and ventricle, they contract on their own, but you see here the interval between PP interval is equal, which means the atria are contracting regularly. Also, the RR interval is regular, which means the ventricle are also regularly contracting, which means that the atria and ventricle are independent of each other, but they are contracting regularly, right? So again, first degree heart block we talked about, there is just a prolonged PR interval that is more than five small boxes, right? So if there is just prolonged PR interval, we call it as a first degree heart block. Next, we talked about second degree heart block, which is Mobitz type 1 and Mobitz type 2. Mobitz type 1 we also call as Wenke back, right? Now, in this, what happens? I told you the PR intervals is progressively increased until a beat is missed, right? And in type 2, we saw there was a constant PR interval, right? But a beat is missed. And in third type, we see complete heart block. There is no coordination between atria and ventricle, both contract on their own, right? So after PR interval, we're going to take a look at the QT interval, right? So as we know, QT interval starts from the starting of the Q wave and extends up to the end of the T wave, right? So it includes both QRS complex as well as the T wave, right? It means it covers both ventricular depolarization and as well as the ventricular repolarization, right? So normally QT interval is between 0.35 to 0.45 seconds, right? And there is another formula for corrected QT interval, which we call it as the Brugada formula, right? So Brugada formula is nothing but the normal QT, the QT that is given divided by root over of RR, that is the root over of the distance between two RR intervals, right? So that is called as the corrected QT interval or the Brugada formula, right? So the importance of QT interval is that prolonged QT interval, that is more than 0.45 seconds, is seen in conditions such as hypokalemia, hypomagnesemia, hypocalcemia, hypothermia, right? And short QTC, that is less than 0.35 seconds, is seen in hypercalcemia, hypermagnesemia, and similar conditions, right? So you have to just know that prolonged QT interval is seen in hypo conditions such as hypokalemia, hypocalcemia, hypomagnesemia, and short QT interval is seen in hypercalcemia, right, and hypermagnesemia. One thing you have to remember that whenever there is prolonged QT or increased QT interval, it predisposes to a very, very, very threatening, life-threatening condition, which is called as Torsades De Pointes, TDP. So Torsades De Pointes is nothing but a polymorphic ventricular tachycardia, right? So when I told you about ventricular tachycardia, this is what you can see. This ventricular tachycardia is having regular rhythm and similar waves, right? What we call as a sine pattern wave, right? So this is monomorphic ventricular tachycardia because all the waves are almost equal. But in case of Torsades De Pointes, it is called as a polymorphic ventricular tachycardia, right? Because of the different types of wave pattern that are seen in this. Also, there is a characteristic pattern, what we call as the cortical ravening pattern, that is seen in Torsades De Pointes, right? So Torsades De Pointes is life-threatening condition that is predisposed by conditions that prolong QT interval, and the treatment for Torsades De Pointes is heavy MgSO4, right? Magnesium sulfate. Next is bundle branch block. So when I was telling about the conducting pathway of the heart, I told you from the bundle of his, the impulse goes into right bundle branch and left bundle branch, right? So whenever there is a block in these bundle branches, this is what we call as right bundle branch block, RBBB, and left bundle branch block, LBBB, right? So whenever we're looking for a bundle branch block, we have to see lead V1 and V6. So very simple, guys. We have to just remember marrow is right, right? So when we're looking for right bundle branch block, we have to look for M pattern in V1 and W pattern in V6, right? So here you can see there is M pattern, right? M pattern. Again here M pattern in V1 and W pattern in V6, right? So here you can see W pattern, here you can see W pattern. So marrow is right for right bundle branch block. And for left bundle branch block, we have a mnemonic called William, right? That is W pattern in V1 and M pattern in V6, right? William, you can see M pattern. So William for left bundle branch block and marrow is for right bundle branch block. So that is how you can easily find out right and left bundle branch blocks. So till now we know how to calculate heart rate of an ECG, check regularity of an ECG, calculate the axis of ECG, check individual waves of an ECG, calculate and interpret the intervals of an ECG, and check out for Brady and tachyarrhythmias. Now we are going to look at the assessment of the hypertrophy. Now we are going to look at ventricular hypertrophy. First of all is the left ventricular hypertrophy. To find out that, we have what we call as the Lyon's formula, Lyons, Lyon's formula, which states that the S wave in V1 plus R wave in either V5 or V6, the amplitude should be more than 35 to be called as LVH, right? For example, here in this V1 we can see the S wave. So there is 2 large boxes plus 3 small boxes, around 13 boxes, and in R of V6 we can see 2, 3, 4, 5. 5 large boxes, that's 25. So 25 plus 13, that is 38, which is more than 35, as a result of which the patient is having LVH, right? Again, below here you can see around 15 boxes here and around 22 boxes here. So 22 plus 15, 37, which is again more than 35, which as a result of which the patient is having LVH. Again, so now taking a look at the RVH. So for RVH, it is very simple. We just have to look at lead V1, right? I already told you that in lead V1, there is no R wave or a very small amplitude of R wave, right? But in cases of the patient that have right ventricular enlargement or right ventricular hypertrophy, the R wave is much more prominent in case of V1. As a result of which the amplitude of R wave must be even more than the amplitude of S wave, right? As in this condition, as a result of which the ratio of R by S, it becomes more than 1 because the R wave is greater than S wave, and hence it demonstrates or it signifies right ventricular hypertrophy. Again, in this ECG you can also see in lead V1, R wave is having more amplitude than S wave, and as a result of which R by S is more than 1, and hence the patient is having RVH, right? So that's it for this video, guys. Just try to master the steps, the proper systematic approach of interpreting an ECG, and you will be good to go. Also, guys, I have kept some important topics in the upcoming video, which is ST elevated MI, non-ST elevated MI, pericarditis, cardiac tamponade, cardiac myopathies, and the effect of drugs in ECG, and also the various common electrolyte abnormalities and their effect on ECG. So I think that portion it just deserves a separate video, and we will discuss about all those things in the next video.